Hi, I'm Michaela Bailey. This is my CPR intro video. I figured it was okay to just do it at home. So for a Labrador Retriever for CPR, we're going to place them in lateral recumbency. We'd prefer for it to be right lateral so that the left lateral is on top, because that allows us for the best access to the heart. The heart is typically on the left side of the body. And then if they're in lateral, that also means that the person doing compressions can be standing at the dorsal end of the dog, and the person doing IV drugs, anything like that, can be standing at the ventral side of the dog, so no one's in anyone's way. So we're gonna, when they're in lateral, for a Labrador Retriever, usually they're round chested, so we're going to do our compressions at the widest part of the chest. So it's usually the 5th intercostal space. So when you take their arm back and where their elbow aligns with their ribs, that's usually where the 5th one is, or you can just manually count, but basically just at the widest part of the chest. And then that allows us to be pressing right over the thoracic pump. And we're going to be doing 100 to 120 beats per minute. It's quite fast. It's like the Staying Alive song, that beat. So you're going to get tired. And then when we press down, we're going to go either 1/3 to half of the depth of the dog. And then when we come back up, we're going to allow the body to fully recoil, that chest to fully come back to where it's supposed to be. And that allows the heart to refill with blood. If the heart doesn't refill with blood, we're not doing anything. We're not circulating anything. So this allows us to do the best interpretation of an actual heartbeat, for it to refill and then compress, and then refill and then compress. For our airway and breathing, again, so they're going to be in lateral recumbency. You're not going to stop that when we're doing our intubation. Just allow them to stay in lateral recumbency. So you got to have a really great RVT or DVM doing the intubation that can do it while they're in lateral, and do it in that first cycle. So start compressions first. Always start compressions first. We're not going to worry about the airway until we've started our compressions. And then while the person's doing their first 2 minutes, ideally in the first 30 seconds to 60 seconds, we're going to be placing our ET tube. And then you can set up the ambu bag or set them up to the oxygen, to the anesthetic machine, and with just oxygen, and be manually breathing with the bag. And we're going to do 1 breath every 6 seconds. And it should take an entire second to breathe in and breathe out. So it's going to be an entire second to breathe in, and then you can let go. So we don't want to hyperventilate the patient. We're going to do nice and slow every 6 seconds. It's about 10 breaths per minute. And then when we have all that going, we can be setting up our ECG and our capnograph. So our ECG is important to obviously give us the heart arrhythmia, or the heart rhythms on the monitor. And then so it can tell us if they're in asystole, if they're PEA, if they can be defibrillated, that kind of thing. And then our capnograph is going to give us our end tidal CO2, so that tells us if we're going to have any return of spontaneous circulation. And it just helps us indicate our pulmonary perfusion and the cardiac output. So when we are putting in IVs, the one that we're going to go for immediately is the peripheral. So that's just your basic cephalic or saphenous IV catheter. If we don't do that one, we can do our IO, so our intraosseous, I can never say that right, intraosseous catheter. So that's directly into the bone. So usually into the humerus or the tibia. You might have seen people do that in like neonates, but it can also be done for CPR purposes. If we're trying to get our peripheral and it's being very difficult, we do a venous cut down. And so that is an actual surgical technique where we shave, we scrub, and then we make an incision, and we use hemostats to isolate the vein itself. And then you can place the catheter directly, like it's right there, directly into the vein, usually the cephalic vein. And so, yeah. If we can't gain vascular access, we're going to give drugs, IT, so intratracheal. So place a red rubber down along with the ET tube, and then we're going to dilute all of our drugs into 5 to 10 mils of saline, and then you're going to double the dose. So we're going to do, you can do epinephrine, atropine, and vasopressin. Those are the only 3 drugs you can do intratracheal. And like I said, they have to be diluted, and they have to be, and you're going to double the dose, and then every time that you instill it, you're going to follow with a syringe of air or a syringe of 0.9% saline to actually make sure that it's not just sitting in the red rubber and it's going into the body. Hi, I'm Michaela. This is my CM Nicole and my CM staff, and we're going to be doing CPR today. This is our 30-kilo patient who is just coded, about a Labrador Retriever size. So can you please start the timer? This patient has coded. Can you intubate and can you get IV access?
Intubated.
Can you breathe every 6 seconds, please?
IV placed.
Perfect. Can you set up monitoring equipment, please? At the end of this round, we're going to give a shot of epi, so we're going to give 0.3 mils of epi. Can you please get that ready?
0.3 of epi.
Thank you.
30 seconds, right?
Okay.
A minute. Thirty seconds left.
We're going to switch in 30 seconds. No pulse. I've got to keep going. Can you give the 0.3 mils of atropine, please?
0.4 mils of epi given.
Thank you. Our next round is going to be atropine. We're going to give 3 mils. Can you please get that ready?
3 mils of atropine. One minute, please.
gonna switch in about 20 seconds. But there's so many. Okay, still no pulse. We're gonna keep going. Can you please give the 3 mils of atropine?
3 mils. 30 seconds in. One minute.
We'll switch in 30 seconds if we need to. Okay, still no pulse, but the owner has elected to stop CPR.